We are very pleased to have our next presenter here. I have with me Kanisha Macau, who is our outreach liaison as well as health educator for Black Infant Health Program, and she will be introducing our next speaker. So please come to your seat and we will start now.
Yeah, well, working for Black Infant Health, I just have the privilege of seeing all these beautiful Black women day in, day out, and on their behalf, thank you so much for being here, and thank you for all of the work and the care that you all provide. So our next speaker that I have the honor to introduce is Miss Candice Charles. So she is an MPH who serves as the Research and Evaluation Manager for the California Coalition for Black Birth Justice. In her role, she leads the evaluation of the coalition's Black birth equity focused on programmatic activities and coalition research efforts. In this role, she has overseen the publication of the State of Black Birth Equity in California 2025 report, which is an amazing report. And its companion web platform, the California Birth Equity Connect. Please go ahead and look it up. Read it on your after this. In addition to her work with CCBBJ, she has worked as a national and statewide collaborator and strategic partner on topics like defining community-rooted evidence and expanding midwifery access. Previously, Candice worked with Cherished Futures for Black Moms and Babies as an internal evaluator, and prior to that with South LA-focused organization, Community Health Councils, to embed the community-based participatory research model into organizational practice. She received her BA from New York University in Global Health and Anthropology, and her MPH from Columbia University's Mailman School of Public Health, where she focused her studies on both global and US-based sexual and reproductive health and gendered violence. Candice enjoys translating her passion for this work through various modes of artistic expression, including pottery and ceramics. Without any further delay, Miss Candice Charles.
Hello, everyone. Good afternoon now. Thank you for the introduction. Here are my slides. Great. So I'm so excited to be here with you all today. Back up. So excited to be here with all of you today to share, mostly with this presentation, the findings from that landscape report that was just described, but also just want to inject some more hope into this room. I think we've had some really great speakers thus far who've been able to do that. I'm just going to stay on that course as well. So I wanted to title my keynote address today, Meeting This Moment. As folks have already mentioned today, we're in turbulent times. We're in somewhat chaotic times, times where when our work is being threatened by forces outside of this community that we've built. But we have legacies that we can learn from, legacies of Black scholars, of civil rights leaders, of just individuals who have continued to fight, no matter what's happening around them, no matter what the external forces are saying. And so I kind of want everyone to start to think a little bit about what meeting this moment means for you, not only as community members, as folks that do this work, but also as individuals. How can we kind of turn into ourselves and tap into that lineage of fight that we all have from our ancestors and from the people that we know around us? Great. So just a little bit about me. As you know, my name is Candice Charles. I have my MPH, but I am more than my profession and my name. first thing that I'll mention here is I'm from New Jersey, and I'm very proud to be a Jersey girl. Thank you. Thank you for the claps. And so I'm an East Coaster, but I love the West Coast. I'm here to stay. I've been here about 4.5 years, and I think there's something really special about the innovation that I've come across in living here, especially around this Black birth justice, Black birth equity promoting work. As was mentioned in my bio, I am a ceramicist. I make pottery. I think having an artistic practice is really important in this work. No matter who you are and what you do, you need to have a place to kind of translate and put the tough days into and the joyful times as well. And so ceramics is really where I do that. There's a little world image down here. I'm not a polyglot, but I do like learning languages. So because I like communicating with people and getting to know people. And as was also mentioned, I did do some global health work as a student coming up. And I love to read. I love to read books. And I actually wanted to share something that I learned yesterday. I spent a little bit of time in San Francisco the last couple days as I was preparing to come here, and I was able to go to the Museum of African Diaspora, the Museum of the African Diaspora. It's an art museum that's next to the MoMA in San Francisco, and they have an incredible exhibit right now called Unbound. And as a part of that exhibit, there's a number of artists that are a part of it, but one of them, Rashida Phillips, talks a little bit about the connection between Blackness and the lineage of Blackness in the diaspora, really, from like a Pan-African point of view, and the relationship with time. And so she talks a little bit about how time is the master's tool, and that Blackness as it's existed, especially in the American context, has been able to subvert that. We're often subverting that with the ways that we show up for each other and community with each other. And she says, this is a quote, Blackness itself can be read as a theory of time, layered, nonlinear, expansive. To decolonize time is not only to resist imposed schedules, but to claim freedom, how we measure, imagine, and live it. And I think this quote really connected with, I think, something that Dr. Melissa Franklin said a bit earlier, and others on the panel really highlighted, especially around this measurement piece, is we get to decide how we measure progress, how we measure what is evidence, how we measure what works. We've always done that as a community, and we should continue to do so. The last image here, the fist. I'm an activist for many things. I believe in many, many things. As was mentioned in my bio as well, I'm a fierce midwifery advocate, and hopefully will be a midwife at some point. So I've been starting on that journey myself. All right, and like I said, y'all, I like books. I like authors, so you're going to see quotes. You might hear a poem later, just previewing that. But this quote here is from one of my favorite authors ever, James Baldwin, from his book, No Name in the Street. You might have heard this quote. It's one of his more famous ones, I think, is, "Not everything that is faced can be changed, but nothing can be changed until it is faced." I think that that is probably one of the most powerful quotes, at least that I've held on to, especially in this moment, in which so much of what we've done, the progress that we've made, is under attack by external factors and the powers that be. All right, but before I get into talking about the report itself, I want to know who's in the room. So I'm going to want to see a show of hands, and then I think via the Zoom, folks can write in the chat. So if you want to write in the chat where you're coming from, who you are, what's your connection to the work, that would be great. But for the folks in the room, a show of hands. If you are a physician, please raise your hand. Physician, thank you. A nurse. All right, strong nursing participation here. A midwife. Great, thank you. A doula. Amazing. How about our researchers? Any researchers in the room? Wonderful. And if I didn't mention you, why don't you just shout it out if you didn't call your profession? Public health, social work, lactation, health education. Wonderful. Thank you all. All right, so a little bit about the organization that I work for and with, the California Coalition for Black Birth Justice, or for short, the Coalition, or for even shorter, CCBBJ. We are a relatively new organization. We're still pretty young. We are in our 3rd year of operation at this point. But we are an organization that was born out of a recognized need for a unifying force across California to talk about what's happening birth equity-wise, birth justice-wise, what progress are we making, what goals are we setting together as a group that's in conversation with each other. Because I think what I've heard from folks identify often is that there's so much incredible work that's happening across the state, but folks just aren't talking to each other. We don't know what's happening in the Bay Area as opposed to what's happening in Los Angeles or Sacramento or the Central Valley or the Central Coast. There are folks that are maybe doing similar work, that have similar priorities, but they've never met, and they don't understand how they're taking these pieces of the pie in tandem together. And it unfortunately, it hurts the work, I think. It hurts the work when we're not in conversation with each other and we aren't aware if we're moving in the same direction at the same time. And so that was really the impetus behind the creation of the coalition. We, at the moment, you'll see here at the bottom of the slide, this is our kind of our full-time staff, our backbone team, as we like to call ourselves. But we also have a group, I believe now, of 16 or 17 strategic advisors that make up a contingency of folks that represent people from across the state of California that approach this work in different ways. We have physicians, we have nurses, we have researchers, advocates, people who have been in this work for decades, people who are newer to this work, but they all share a passion for Black birth justice, and they all have some level of expertise in their own lane. And so this group of strategic advisors are the folks that help us decide what is it that we need to do in this work, and then also help us collectively prioritize what needs to be done in the state of California. And so I actually won't be talking about the first piece of work that we produce as a coalition today, but you can find it on our website. It's the 2023 strategic agenda that we released, which is a part of that collective prioritization that we did with our advisors that really outlines where we think we need to go as a state and where we should focus on in order to really push Black birth equity forward. So again, just to underscore, we are connecting and convening key leaders, our strategic advisors, as well as other partners. We're supporting the Black birth justice workforce, and we're partnering with healthcare and public agencies to implement change through quality improvement work as well. Thank you. And since there are so many nurses and physicians and folks who work in hospital here, if you are more curious about our quality improvement work that we do with hospital partners across the state, please come talk to me afterwards. All right, the report, the meat and potatoes of this presentation. So you can also find this on our website as well. But this report was released last year. I can't believe it's 2026, but 2025, the State of Black Birth Equity in California. And this report was a labor of love. There's a lot of research that went into this, both secondary and primary sources. This is an outline of what you'll find in the report, and I'm going to get into it actually after this. So the first chapter is a literature review. If you don't know what that is, it's just a review of articles that have been published around Black birth justice and equity. And we really wanted to do some trend analysis of what are folks writing about this work and subsequently what's missing. The second chapter here is an organizational and policy tracker. We wanted to look at what organizations are doing Black birth equity promoting work or work that touches this work in any way or influences it. And so that's in that tracker, as well as policies that do the same. The third chapter is a power analysis. The fourth, some findings from clinician focus groups that we were able to do in 2024. And then the last chapter is kind of what we're calling like a micro study almost. It's specifically around some Los Angeles clinic site visits that we did, because we wanted to get at the outpatient experience here. We don't often hear, and maybe more now than ever, but at the time especially, we weren't hearing folks talk about what that experience was like, and subsequently what things we can do to improve it. All right, so everyone take a deep breath. I'm gonna take a deep breath. I'm going to talk a lot, so bear with me. I'll try to keep this or make this as interesting as possible. So, first chapter, chapter 1, key trends in the literature. And again, as I mentioned, we wanted to break this down in a way to understand where are the gaps, who's not being written about, what's not being published about, and really bring that to the forefront. So the first trend that we established here, or we found here, was the established trend of racism as a root cause. So an established trend is essentially something that it's canon in the literature. It's widely been accepted. Folks are quoting folks over and over again, and it's something that's mentioned time and time again, and you find it almost everywhere when you're looking at pieces, articles written about Black birth equity and justice. Now, there still is some pushback. There has been some pushback, even recently, of folks publishing around questioning racism as a root cause, but it's not as common to see pushback. The second trend here is an emergent trend. This is something that, as is described, is emerging and perhaps isn't as canon as racism as a root cause, but has definitely gained quite a bit of momentum in the last few years. And this is patient-reported experiences, hearing from folks in their own words, and this is heavily qualitative data as well. The last trend here is the rising trend, which is non-dominant models of care. When we say non-dominant models of care, we're talking about centering group models, right? We're talking about guaranteed basic income. We're also talking about the midwifery model of care as well. Finally getting some shine in the literature, but not nearly enough. And so we really want to undergird and support this trend as much as possible and keep it moving forward. So as promised, key gaps, because there were gaps, as you might imagine. And so we kind of set this up into two different categories here. So examples of missing populations and then examples of missing subjects. I'm actually going to add a few to this because as we've been kind of going around as a coalition and talking to folks, there's definitely things here that in the report weren't written about, but definitely belong. So in terms of missing populations, we have those with substance use disorders. We're not seeing folks write about the experience of pregnant folks who struggle with this. And we know that pregnant folks do, and so it doesn't help that they're kind of invisible in the literature. Gender expansive and transgender individuals, folks who are experiencing homelessness, those with disabilities, and those who are incarcerated or justice involved in any way. What I would add to this is also folks who are experiencing intimate partner violence or just violence in general. This is definitely a missing category of folks when we're talking about this work in general anyway. And then examples of missing subjects. So we didn't see a disaggregation of Blackness. And what I want to say about this is that I think we have other communities who have done a really good job of really pushing for this. I'm thinking specifically around the Asian community. When they talk about, there are different things that are happening within their community depending on kind of nation of origin. And I think something similar is probably happening in the Black community as well, when we think about folks who are recent immigrants or the children of immigrants having a very different experience than folks who are the descendants of enslaved, formerly enslaved people in this country. And I think we would do better to have a better and a more deep and profound understanding of what those differences might look like in the hospital setting and outside. Second, here we have studies that measure the efficacy of driving change within institutions, so thinking about quality improvement work, studies that chronicle midwifery and doula integration into existing systems and how that's working or how that's not working, studies that explore infertility, and studies that center the postpartum care experience. So, a key takeaway: we should continue to push for institutional recognition of these frameworks despite pressure to shift language. This is something that I wholeheartedly believe, and I know folks are navigating this system and what's happening right now in many different ways, but I think our findings from this particular chapter point towards that. And then food for thought for folks in the room and in the Zoom: what new or unexplored areas of research would you like to see examined? So if you have your notebooks and your pens out, feel free to jot down some ideas that come to mind, so you can go forward with them after this. Second chapter is around key infrastructure findings. And actually, I meant to say this earlier. I think there are a plethora, although there can be more, but there are a number of studies, reports out there that have been recently published around what's happening outcomes-wise in Black birth equity. This report, and as you're starting to see already, is really around the infrastructure that we've built around stretching towards Black birth equity in the state of California. And so what we really wanted to look at as a coalition is what have we built already? What's the health of what we've built? And how can we strengthen what we've built as a community? And so this chapter really gets at that. We're looking at the organizations that do anything related to Black birth equity across the state. We're looking at their approaches and their strategies to the work, and then we're also looking at policy opportunities in this chapter. So a couple graphics here. At the time of the writing of this report, we had identified just under 80 organizations across California that do something in relation to Black birth equity and Black birth justice. And so you'll see on the left side of this slide is a breakdown of where those organizations are actually situated. And it does really map onto the kind of the concentration of Black individuals in California, as you might imagine. So Los Angeles, the Bay Area, Sacramento, these are the areas in California that have the highest number of Black families. But we know that there are Black individuals, Black families, Black pregnant people in the Inland Empire, in San Diego, in Fresno, in the Central Valley, right? And so I think the takeaway from looking at this left side of the slide here is that we need more organizations in these other areas, still in Los Angeles, the Bay Area, Sacramento, but especially in places like the Central Valley and places like the Inland Empire, where we know that Black folks are moving to these days based off of the cost of living and housing policy, et cetera. And so that's definitely something that's like deeply visual here. On the right side of the slide, what you're looking at is the organizational strategic approach. So of these 80 some odd organizations, How are they approaching this work? The most common approach is direct service provision. Really important. We know we have service gaps, and so a lot of these organizations are standing in that gap. Fortunately and unfortunately, right? That's a whole nother conversation about the system that we live in. And second here, we have advocacy, then education, and community engagement. Now, if you're looking down, as we kind of go down this visualization, you'll see that folks aren't doing as much reporting, right? Or quality improvement work, or workforce development, or leadership development, right? These are also really important strategic approaches that our organizations oftentimes want to participate in, but they don't have the capacity to do so or the funding to do so. And so I think one of the major findings from this is that organizations are doing really important work, right? They're doing direct service provision, but they might not be able to do their own reporting when it comes to the direct service provision work that they're doing, or their own data analysis. Or they might be doing education work, but it's not fully connecting to workforce development, right? Maybe they're doing community education, but they want to help build the workforce, but they don't have the capacity to do so. Another figure here. So this piece is around our key policy findings. And so what we ended up doing at the time of this report writing, we identified over 45 policies. And policies could mean bills. It also means initiatives, strategic plans. Most of these, though, are bills. And what you'll see here is kind of the key is telling you what each color represents. So we identified policies that were specifically around birth equity, reproductive health, hospital policy, healthcare access, reparative justice, workforce, child health, economic equity, maternal mental health, awareness, and health funding. And then you'll see here what's been enacted, proposed, failed, vetoed, and then the total here. You'll see the total. Most of these bills and policies that we identified were specifically around birth equity, but we also see reproductive health is basically right up there with it. In terms of enacted bills, reproductive health related bills were the most successful in terms of being enacted, followed by birth equity and hospital policy related bills. Yes, I think what a key takeaway here is that it's challenging to bring a bill from the ideation stage all the way up into it being enacted. And I think that challenge has been illustrated also by the challenge around how do we build in accountability features within these bills as well. It's not enough to only have policy on the books that says folks should be doing this. We also need to build in a mechanism that checks in on that, right? That has some type of consequence for folks not engaging with this new passed policy in the way that they should. Right, so in terms of policy opportunities, we need more community-based infrastructure and funding. That's something that really came through in the organizational tracker, if you remember. Workforce needs investment. We know this. I know all of you know this in the room, right? The healthcare workforce community is hurting in ways that isn't always recognized, I think, in this work. And so we definitely need more support and investment there. Maternal mental health integration and postpartum support, and we need to elevate intersectionality. Key takeaways, I've already kind of mentioned a few of these. The Central Valley, the Central Coast, Inland Empire, San Diego region, they need more resources to increase organizational capacity. Organizations themselves need more resources to deepen and broaden their approaches to the work. And any new legislative activity should target gaps and increase institutional accountability. I know we've been talking a lot about that today. And then food for thought, if you want to note it down or note it in your head, where would you like to see new legislation focus? Especially would love to know from your individual vantage points as well. Chapter 3, we are making it through, folks. I hope everyone is still alive and awake. All right, great, yay. So chapter 3, past the halfway point, key power analysis findings. So again, just to reiterate, as a coalition, we thought this would be important to include because we had fielded a lot of questions and had questions ourselves of, okay, we have all of these ideas and plans for things that we want to do in this work, but who wields the power to make that thing happen? Who do we need to speak to? Who can actually put something on the books or influence the right person or right entity to do the right thing? We didn't have the answer to that question, and I think a lot of folks still have questions around that in the state. And so first, we, when we wanted to embark on this research journey, we wanted to define power because it's hard to work without a framework of what power is. And so we used the Grassroots Power Project definition, which is power is the ability of marginalized communities to reshape their social and political landscape to reflect their needs and visions. It aims to build lasting influence over governance structures, driving transformative change that addresses racial, economic, and gender injustice. So our key findings. So we actually separated power into 3 different categories here. We have visible power, hidden power, and invisible power. So for visible power, those are folks that hold formal decision-making power through policy and economic authority. Those that hold hidden power are folks that influence what is prioritized and decided, often in conversation with those who hold visible power. And invisible power are those who shape our beliefs and narratives around what is right and fair. And so if you read a little bit, I won't read everyone here in these lists of power, but I think I'll call out some important folks. So under visible power, we have the governor, we have the legislature, we have statewide organizations like Health and Human Services, Department of Public Health, we have philanthropy. Under hidden power, we have community-based organizations, we have advocates, clinicians, research institutions, professional associations, which aren't always brought into the conversation but need to be, and invisible power. And I think the big heavy hitter here is the media, right? The folks that really write these narratives and publish them. So you'll see also here on the left side of the slide are some suggestions that we have for folks that hold both visible and hidden power. I'll just read a couple of them. So for those who hold visible power, we implore that they establish formal mechanisms for community accountability. So by that we mean that they are accountable to community, not that community is accountable to them. And that they also align resources and resource allocation with community identified priorities. We heard that earlier on the panel. And for those who hold hidden power, they must activate and align cross-sector supporters, something that we are trying to do as the California Coalition for Blackbird Justice, that coalition building. And then also establish common language, values, and goals grounded in reproductive justice, anti-racism, and the lived experiences of Black birthing communities. chapter 4, and I'm hoping this one will be extra interesting to the clinicians in the room, and also wondering if any of this will resonate with you. So in 2024, we as a coalition embarked on doing some focus groups with folks across the state. And by clinicians, we defined clinicians, or the clinicians that we spoke to were midwives, certified nurse midwives in particular, so folks who are working in hospital, nurses, physicians, hospital administrators as well, and I think we spoke to one in-house quality improvement individual. And so in these findings, we asked folks about their institution's readiness to engage in quality improvement work, the facilitators of the success of that QI work, if they had engaged in it at all, challenges to the implementation of that QI work, and then also fielded from them future quality improvement ideas. So the first piece of our findings here are around institutional readiness. So we had 6 domains here in which we asked folks to consider their own institution's readiness to engage in this work. The first being authentic partnerships with Black-led organizations, engagement in Black community, practices to improve workforce diversity through sustainable initiatives, practices to promote an equity-based work culture, clinical practices to improve Black birth outcomes, and data collection and reporting on disparities within their institutions. And we asked folks if their institution had started it, if they had just begun to explore it, if this was already an integrated practice, if it was an advanced implementation, or they weren't sure and they didn't know. And that's a finding in and of itself, right? If folks don't know what's going on within their system around quality improvement work. And so a lot of folks answered that they weren't sure and they didn't know, especially around authentic partnerships with Black-led orgs, engagement in the Black community, and the big one here for me, especially as a researcher, around data collection and reporting on disparities. So to not know if their institution was doing that means that if it was happening, it wasn't being shared with them, which negates, right, the whole purpose. And so folks also mentioned just beginning to explore for a lot of these as well. So for clinical practices to improve Black birth outcomes, that was definitely the most common response in 2024, as well as practices to promote an equity-based work culture. Now, as I mentioned, these focus groups happened in 2024. A lot has happened since then. And so I do wonder how these responses would change if I were to poll the same clinicians today. And I can't say that I'm as hopeful around it going in the right direction, just given some of the work that we do as a coalition. We're still working with hospitals and talking to clinicians about trying to do equity promoting work. And it's even more challenging now, today, than it was a couple years ago. So here are some of the qualitative findings from that, or it's all qualitative really, but we wanted to give you a visual for the last one. So, so for the facilitators of success, for the folks who said, yes, my hospital is engaging in quality improvement work, we wanted to see what made it successful. So folks talked about leadership buy-in, they talked about workforce diversity being helpful as a facilitator, external help from other community-based organizations like ours and others that do quality improvement work, care team cohesion, and access to data. I'll read one of the quotes here. So the middle quote from a certified nurse midwife, she said, access to site-specific and maybe even provider-specific data seems really important because everyone tends to think it's somewhere else. We can't really do the work unless we make that data very site-specific and relevant so that those people that don't believe that it's us are accountable to actually what's happening within our own institutions. I think one of the panelists said this exactly earlier, that these, like a provider scorecard or an equity scorecard, even if it's just within the system, because we know systems don't really want to share externally with folks what's going on for various reasons, but even if they have that practice within, that this could potentially really revolutionize the type of care that folks are receiving. Next slide. And then we have some findings here around challenges to implementation, of course. Folks, first and foremost, mentioned lack of protected time to do this work. So again, these were midwives, nurses, physicians, folks that really wanted to do quality improvement work, but they have a patient load. They have administrative things to do. And so a lot of them, if they were doing this work, it was on the side in an hour or two, if they could find it and fit it in. It was difficult for them to do it. Folks also mentioned burnout. We hear that all around, everywhere in this work, but of course it's our clinicians as well. Divisions in care team, lack of staff buy-in, implicit bias, and fear. So I'll read the first quote here. This was from a physician. I think the barriers are there's still people who don't believe this is a problem. There are still people embedded that we work with that are in the physician group and in the nursing group and the administrative group who think, really? Is this really a problem? So those barriers are, how do you get those people to listen and turn around that? How do we get all of the caregivers to listen better to women? I'll also read the third quote here. This one is around fear, again from a certified nurse midwife. You can't listen if you're feeling scared. The provider's feeling scared, and so then the provider stops listening because they're worried about pushing their agenda, because they're worried that they're no longer fully behind autonomy. And so I think for me as a researcher, this last challenge was the most surprising for me to hear from folks, and it was validated from other folks in the focus groups that not only are community members kind of coming in the hospital system afraid, that providers too can feel and do feel fear in certain scenarios, and that can be a challenge in terms of continuing to support collective decision making in the hospital setting. And then just a couple of the future quality improvement ideas that we fielded from folks. There's more in the report, but these are just the 4 that I chose. I think I really want to highlight here number 3, facilitating relationship strengthening through team building activities within clinical staff ranks and between clinical staff and midwives and doulas. Midwives, I think we're talking about home-based midwives, right, in this sense, if they're not already working in the system and there might be a transfer situation happening. And so we also heard folks talk about that earlier, right? You talked about that, how important it is to facilitate that relationship building so it's not adversarial when a doula presents with their client. Food for thought. What challenges or barriers to enacting systems level change are you coming up against in your respective areas of work, especially for those who are working in hospitals? I think I would love to hear afterwards, or if you have comments after I'm finished with my slides, I'd love to hear it. Last chapter, folks. Chapter 5. Chapter 5, as I mentioned before, is the kind of microcosm study that we did specifically in LA when we did our Los Angeles clinic visits. And essentially, we posit that what we heard during these visits is probably happening, perhaps happening in other parts of the state. Of course, we'd have to validate that. But the point was to get the ball rolling on figuring out what this outpatient clinic experience is like. And so this I'll be pretty brief around our findings for this, and it really does map onto the findings that we heard from the clinicians in the last chapter. But for this, we spoke to birthing folks, to mamas, to parents, who first talked about their care experiences, specifically in the outpatient clinic setting. First, unfortunately, experiences around fear and coercion when it came to the care that they were receiving and procedures that they received, challenges around receiving timely treatment. A lot of the parents, birthing folks that we spoke to were in the category of high risk, but were not referred to the right level of medical care in the timing that they should have been. Folks talked about a desire for racially concordant care and not being able to receive that. They talked about challenges with bedside manner and staff competency, and also having a lack of options for care. This maps onto this desired experiences piece here, where folks talked about wanting community-based models of care to be available to them, and that just not happening. They talked, again, this is kind of connected to this desire for racially concordant care, recruitment and retention of racially diverse healthcare providers being a hope and a wish. For more upstream solutions to happen. So when we're thinking about, we're all in this soup of systemic racism, and what does that mean for the material conditions of these parents that we spoke to? And it's not enough for us to only talk about what's happening in the hospital, to only talk about what's happening in the outpatient clinic experience, but to also talk about what are our neighborhoods looking like, what resources are folks able to get a hold of. And then again, related to resources, wraparound services, and having more of that. All right, so I've made it through all of the data, essentially. So thank you all for sitting through that. I hope it was interesting for you, even if there were just kind of pockets here and there that you could really hold on to. But what I wanted to do before we head into any questions that anyone might have is end us off with a poem from one of my favorite writers, Lucille Clifton. She is no longer with us. As you can see, she passed in 2010, but she did win the National Book Award for this book of poetry called Blessing the Boats, a prolific Black female poet who had a lot of firsts, actually. And actually, before I read this poem, I wanted to read a little something else that she wrote, very short, because I think it goes with this meeting the moment subject that I put at the first slide. So she writes, "The lesson of the falling leaves. The leaves believe such letting go is love. Such love is faith. Such faith is grace. And such grace is good." And I think for this quote, it made me think about, in this moment, what are we shedding, but also what are we gaining, right? In this challenging moment where things seem to be falling, what are we picking up as well? And for this poem, Blessing the Boats, at St. Mary's, may the tide that is entering even now, the lip of our understanding, carry you out. Beyond the face of fear, may you kiss the wind, then turn from it, certain that it will love you back. May you open your eyes to water, water waving forever, and may you in your innocence sail through this to that. And for the folks who want a little bit of interpretation, when I think about this poem, it's about uncertainty, it's about difficult times, but it's about working and sailing through it, like our ancestors have always done, like we can do as well. And that's it. Thank you. If anyone has any questions or comments, you can see our website up here. You can follow our our handles on Instagram, LinkedIn, and YouTube, and then this is my email. So if anyone wants to continue the conversation with me, hear about the work that we're doing at the coalition, or just chat about what's going on in the world, please email me. You can also download the report too, if you want to scan the QR code. Those are all my plugs.
And if anyone has any questions, we can come to you with the mic. Oh, you're good.
Thank you for your presentation. It was really great. I'm really curious because you obviously, as in the coalition, have this great partnership with CDPH. And as your data mapped out, a lot of the service delivery is at the county level and at the CBO level. Where do you expect your advocacy to go in the next sort of 12 months, given the priorities of the state are going to be very different to the counties and the CBOs and those doing the delivery?
That's a great question. I think I would take it back to what our kind of our original mission and ethos is as a coalition, is that we are and want to continue to serve as a unifying force in this movement. And so, as I mentioned at the beginning, we released a strategic report in 2023. We actually worked really closely with CDPH to release their strategy document that they recently released around where we go and move as a state. And so we, as a coalition, are actually working in partnership with statewide entities like CDPH to do that collective prioritization. And we want to continue to do that because we can see how, again, like we are working tirelessly as a movement to try to move the needle in the right direction. But when we don't have a unified vision, when we don't have a unified strategy, sometimes we're just working in opposite directions. And given how hard everyone works in this room, it's not worth doing that right anymore. And so I think, to answer your question a little bit more directly, I think it's also scanning for what are all these priorities that folks are releasing now across the state, and how do we bring them together and make sure that we're all working in that same direction. Yeah. Thank you. Any other questions or comments, feelings, poems? Well, it doesn't have to be a poem. You can.
Lisa. Yeah, go for it, Ron. Yeah, you said there's an online question, and then we can take Lisa after.
Yes. Okay. Perfect. Thank you. Okay. This question asks, does the coalition have plans to develop indicators of progress towards Black birth equity?
Yes, the coalition does have plans to do that, again, in collaboration with our strategic advisors, but also with other partners. That is why my email is up here as well. It's like we want to make sure that we're including as many voices as possible across the state, especially when we think about collectively creating these indicators of success. As Dr. Franklin mentioned earlier and others, the indicators that we've kind of been given from our folks who fund this work aren't working. And we need others, and we know others in terms of our collective community knowledge. And so the short answer is yes, and we'd love for you to be involved, whoever you are, online, and to folks in the room as well.
Okay, I have a question here from Lisa.
Thanks. That kind of stole my thunder a little. So it sounds like you're going to be doing some quality improvement work around indicators, but I wanted to know what was next for your organization, for you, now that this report is out. And then I was just curious, the clinic conversations that you had, do the providers or the institutions, are they going to do anything with those insights from the patients that have gone through those experiences? Is there like a feedback there that's going to happen?
Thank you for your questions. I'll take the first one and then I'll do the second one. So where we're going post this report is, well, first we're speaking about it, we're disseminating, we're trying to get as many folks aware of our findings as possible, and the right folks as well. So different chapters speak to different folks. So when it comes to like the organizational tracking piece and impressing upon funders and philanthropy that folks need capacity building help. They need more money. They need unrestricted funds. They need things that aren't project based only, because that really challenges a lot of community-based organizations. So it's communicating things like that to the right people. It's working with other organizations that do legislative work and ideation around legislative work to map our findings onto where they're going with their work as well, in partnership with them. I think also it's about continuing to do that collective priority setting. We came out with that priority strategic document in 2023, but that was 2023. And times are a little bit different right now, right? And so it's about also revamping that, using our findings to help us revamp that, and think again about what we're prioritizing as a movement. In terms of the clinic findings, that is an excellent question. We don't actually have a mechanism to make sure that our findings from this report are materially changing the type of care that's being provided in the clinics that we spoke to, but we should. So thank you for that. Take that as a very strong suggestion.
Okay, I see 3. So 1, 2, 3. We see you. We're going to start over here.
Hi, thank you so much for your presentation and for your work. I appreciate that you are focusing on making sure that all the players are at the table. I think that's really important. As a registered dietitian, I would remind everyone in the room who is not working with registered dietitians to make sure the dietitians are at the table. So whether it is us really being able to proactively address nutritional deficiencies or looking at nutritional markers sooner in the prenatal period, or even prior to the prenatal period, that is absolutely incredibly consequential. And so whether it's our inpatient registered dietitians working in the L&Ds, the mother and baby units, our WIC dietitians in private practice, I think it's really our GDM dietitians. It's really important that dietitians also be at the table. So when we're talking about clinicians, making sure that dietitians are a part of that discussion can really help us to move the needle. It's not the end all and be all. We all have a role to play, but I often don't hear them mentioned.
Thank you. Yes, please clap. Agreed.
Hey,
Hi.
how you doing?
Good.
Quick question. Is the coalition looking at midwifery-led care and changing, looking at addressing the care model that a lot of our Black community members are not forced, but limited options on where they receive their prenatal care? And so is there any look at supporting the midwifery workforce and addressing the disparities in compensation for midwives, the higher rates of liability insurance, the structural things that are preventing them from actually being able to provide care to our managed care patients in various counties in California?
Thank you so much for that question. So myself and another one of my colleagues at the coalition, we're actually a part of a group called Midwifery Access California. They are a group that's been strategizing around everything that you mentioned, right? Reimbursement rates, challenges around building, operating, and sustaining birth centers for home birth midwives. It's also a group that brings together certified professional midwives and certified nurse midwives, which I think is revolutionary in some ways, unfortunately, in this country at this moment. And so also supporting education and bringing more midwives and more diverse midwives. And so I'd say the work that we do around that as a coalition is primarily seated in our participation on that statewide group and supporting that statewide group's work as well. I think going forward, as we think about collective prioritization and that strategy document that I've been mentioning, is how do we make sure that whatever we're producing next is really rallying behind supporting the midwifery model of care in California and making it accessible for Black families in particular. And so I think we have work to do around that as a coalition, and really figuring out ways that we fit in that movement and keeping the momentum going. But yeah. But I do really suggest folks look up the Midwifery Access California group. They have an incredible amount of education around midwifery in California, and they've been doing incredible work.
Thank you for such an amazing, really insightful report. I had a question about the slide where you had all the organizations and you did this amazing analysis about some of the gaps where direct service provision, you're not able to do the research on the direct service provision and so on and so forth. And I was just really curious, across all of the California organizations, how many of these organizations, I'm not sure if you looked into it, but how many of these organizations partnered with each other on their gaps?
That's a fantastic question. I don't have an answer to that question, but I do have indirect answer, I suppose, or a comment. And so I think what I didn't end up showing in this presentation is that we did build a web platform based around, I should have mentioned that, but anyway, we built a web platform based around specifically the findings from the organizational tracking piece. And a part of that web platform, or the idea behind it, is that we wanted to create and have a place in which organizations can collaborate with each other so that they can see that, hey, I'm doing this type of work in this part of the state, you're doing that in this part of the other part of the state, we should work together. And so the web platform, we're actually in like the beta testing period, but we are accepting users. So if folks want to join it, please reach out to me. I will create your login credentials. And that's the place where we hope to start to see that type of connection happen. Because it's a little bit difficult to get at that type of data without talking to a ton of people. And like, you know what I'm saying? So yeah, that's my non-answer to your question.
Thank you so much. I think just a trend I see in this work is that we always operate in silos. And so sometimes I'm like, oh, you do that work? Well, we're working on the same thing. I want to learn from you. And then, you know, we exchange ideas. So thank you so much.
Yeah.
Appreciate it.
And the platform is called CA Birth Equity Connect. You can find it on Google if you want to just request credentials, or you can email me and I will create your credentials for you.
Thank you. Thank you. That was such a great presentation and the report. I think you did a phenomenal job. Thank you so much.